any significant deformity and without any significant functional impairment. But later on, it was found that there are severely distressed fractures, severely comminuted fractures. About 15% of cases require surgical treatment either in the form of tense nailing or the internal open reduction and internal fixation with plating. So let us come to our main topic, that is that tense nailing. Unlike preservative management, it provides stable fixation and early mobilization and reduces the risk of non-union and malunion. Tense is less invasive, resulting in a smaller incision, reduced soft tissue damage and fewer potential complications, making it an attractive option for managing distressed fracture of the clavicle. So we conducted a study between March 2022 to March 2025 on 25 cases of clavicle fracture, mid-third fracture, all were simple distressed fracture according to AO classification 15D1 and 15D2. The age of the patient was 16 to 48 years. No comorbidity was found in our study group. So all patients treated by titanium elastic nailing in my hospital. So the mode of trauma, no traffic accident was the main mode of the trauma, whereas fall from height and fall on out the step side was the other mode of the trauma. So these are the typical mode of injury, the fall on the shoulder to protect the head injury in the road traffic accident. This picture is taken from AI. And this is a typical clinical presentation. A bump at the site of the fracture and the skin appears as if the fragment will penetrate the skin. And this is the radiological typical presentation, more than 2.5 centimeter displacement. And the dead type of cognition are the radiological indication for the surgical treatment, either in the form of tense or internal fixation with the plate and a screw. So these are the already explained. The simple fracture were taken into consideration. Distressed simple fractures are spiral or oblique or transverse or short oblique, 15B1 and B2. The patient tries to find the affected lip elevated and the arm are hanging outside the table so that we can facilitate the abduction and external rotation at the shoulder to facilitate the abduction of the fracture by closed wing. The incision, a small incision, has a transverse or longitudinal incision about 1 to 1.5 centimeters, just lightened to the sternoclavicular joint is given. Adapter making an incision, we make a hole with the help of drill bit, and then we make this hole continuous with the intramedullary canal of the clavicle. But this is very, very crucial step. One should take his own time and use tips and tricks to do this step, because the heart and lung, like vital structures, are waiting for an instrument to escape. So after making the hole, we did tense nailing after close reduction or mini incision reduction. So the immediate post of pain management and immobilization, at the 2 weeks we did suture removal, at 6 weeks radiographic assessment of the fracture area, and 12 weeks functional assessment, and if required, the implant removal was done. And the operative time was 30 to 60 minutes, whereas fluoroscopic time was 10 to 30 seconds, and the blood loss was 20 to 50 ml in all our cases. So the excellent result in 76% of cases, whereas 16% cases were good results, and fair and poor results were 4% each in our study group. The complications are nail bite, superficial infection, and the malunion, each were 4%, whereas hardware irritation was 8% in our study group. And these are the few cases. You can see that 15B1 fracture treated by titanium elastic nailing, beautiful surgery without use of any instrument. The reduction has been done only by shoulder movement, external rotation and abduction, and with the help of the thumb and index finger. The beautiful surgery. And this is another case, yet another case of the 15B1 fracture treated by titanium elastic nailing. Yet another case of 15B1 fracture treated by titanium elastic nailing. These are the 15B2 fracture. This is 15B3 fracture treated by titanium elastic nailing. Ideally, it should be treated by open reduction and internal fixation, but we did tense nailing, and you can see the 6-month follow-up, the beautiful radiological union. And this is the functional result. You can see time is less. So the limitation of this surgery is a small number of cases included in this case, in this study. So the short follow-up period and retrospective design. So a study with large number of population and long duration of follow-up and prospective study is required to establish this modality of treatment as an attractive option for the treatment of displaced fracture of the take-home message is tense nailing is effective for the clinical fracture with good to excellent outcomes, minimum complication if the patient are selected properly and the technique is performed properly. The further study are needed to confirm the long-term efficacy of this. This work published in International Journal of Orthopedic Science.
Why do small YouTube creators fail to hit YouTube trending? Poor titles, weak hooks, and outdated keywords kill your views before they start.
17 years old man, the road traffic accident was the mechanism of injury, clinical presentation, severe pain and deformity, and inability to bear the weight on the right side, whereas the left side he had a gallaging fracture. So the challenge was the patient presented with significant surgical burden and the major long bone fracture concurrent with the complex forearm fracture and dislocation, which is called the gallaging fracture and dislocation. And this is the X-ray of the femur, the sharp femur, mid-third fracture of a 17-year-old gentleman, and the forearm gallaging fracture, severely displaced fracture. Inner canal, it was narrow, so the nailing was difficult. The standard treatment is nailing, and ideal treatment for this gallaging fracture is the plating. But I opted nailing, although it was difficult nailing in the both fracture and the slight distraction, the tense nailing for gallaging fracture. And this is not reported in any literature. For such a severely displaced fracture, the tense nailing should be considered. In fact, there is no literature present for the tense nailing for this type of gallaging fracture. So we did for the minimally, because it is minimally invasive, and periosteal and endosteal blood supply are maintained in both fracture, and the interlocking nailing was done in the sharp femur, and only 9 millimeter nail could be negotiated because the narrow medullary canal. So there is slight distraction, as you can see in this picture, but we did locking. It was difficult nailing. So the goal was to provide sufficient stability for early mobilization despite of an anatomical constraint, and implant was 9 millimeter nail and technique was minimally invasive, and whereas in this left radius, the gallaging fracture, we did tense nailing. In this case also, the 2 millimeter tense nail was with this due to the narrow canal, but this is a 6-month follow-up. You can see I sent this X-ray in Indian Orthopedic Research Group, IORG, and they told to revise this case, bone grafting and plating for gallaging fracture. So, but I left it and wait for, this is the 8-month follow-up. Still there was better union than 6 months, but this was not hypertrophic, and this is 11 months, you can see. So after waiting 11 months, the union is complete in both the fracture. The secondary colors are been formed. It was not hypertrophic non-union, it was the union, secondary union was taking place, although it was delayed union. But this is the functional result. You can see that supination, pronation, and wrist movement, flexion and extension all are present. And the tense swelling is provides sufficient stability for secondary union even in length critical fractures because the narrow canal and the length should be maintained to and DRUJ should be reduced properly. We followed the throughout the 11 months for this maintenance of the length and DRU maintenance. And advantages of this minimally invasive approach for Gallagher fracture and femur is minimally invasive and reduce operative time and significantly minimize minimum blood loss. And this is the conclusion that the TENS is viable, effective alternative for plating for the complex forearm injury. The successful management of this double fractures case confirms that interlocking nailing of femur and TENS aids higher union rates and excellent functional outcomes. This approach should be considered for Gallagher fracture in adult after further studies, because I think this is the first case in severe Gallagher fracture. I did TENS. So this case was published in International Journal of Orthopedic Sciences. Provides stable fixation and earlier mobilization and reduces the risk of non-union and malunion. Hence, is less invasive, resulting in smaller incision. Conducted a study between March 2020 to March 2025 on 25 cases of the displaced fracture of the clavicle. The age of the patient was 16 to 48 years and no ये फ्रैक्चर है टिबिया का, कई भागों में विभक्त है और इसे डॉक्टर ठाकुर इनोवेटिव टेक्निक ऑफ सुप्रापेटलर नेलिंग ऑफ टिबिया के द्वारा ऑपरेशन किया जा रहा है। इस वीडियो में देख सकते हैं कि गाइड वायर को डाला जा रहा है और गाइड वायर फ्रैक्चर रिडक्शन के बाद और फोर्सेप्स के द्वारा बिना चीरा लगाए रिडक्शन फोर्सेप्स के द्वारा। हेलो फ्रेंड्स, आई एम आरसी ठाकुर, ऑर्थोपेडिक सर्जन, छपरा, बिहार। टुडे आई एम गोइंग टू प्रेजेंट माय innovative work named Dr. Thakur Innovative Technique of Suprapatellar Nailing of Tibia. Tibial fractures are most common among the long bone fractures in human body. These are usually caused by high energy trauma like fall from height. This shows Dr. Thakur Innovative Technique of Suprapatellar Nailing of Tibia is safe, cost-effective method of treatment for metaphyseal tibial fractures. Intramedullary nailing technique is the treatment of choice for metaphyseal fracture of tibia in adults. In treatment of metaphyseal tibial fractures, concerns regarding difficulties with reduction due to anterior deformity becomes a challenge. Suprapatellar nailing becoming popular choice for treating metaphyseal fractures. It is highly specialized surgery and requires very highly specialized instruments, sets and implants that tends to be very costly. Dr. Thakur Innovative Technique of Suprapatellar Nailing of Tibia delivers 100% satisfactory union of fracture in safe and cost-effective way. No special instrument or jig are required. A protective slip and a trocar can be used from PFN A to Z, and color-coded infrapatellar tibial nail extractor can be used to introduce the nail in proper position. Between March 2020 to March 2021, Dr. Thakur Innovative technique of suprapatellar nailing of tibia conducted on 25 patients to fix their tibial fractures. The patients having tibial fractures with no involvement of articular surface were included in this study. Was fixed by Dr. Thakur innovative technique of suprapatellar nailing of tibia. This is the flow diagram how the eyes over from PF and A2 set, trocar and malleable guide wire and stout and hard guide wire. Reamer, these are the passage of slave, trocar and hard guide wire in the retropatellar space in AP and lateral view. Passage of reamer over the guide wire after percutaneous reduction with the reduction forceps in AP view, and this is in lateral view. Nail entry over the guide wire and nail entry in distal fragment in AP view. Nail entry in distal fragment in lateral view, and then both locking screw introduced in proximal fragment. In AP and lateral view, all the three screws introduced in distal fragment by freehand technique. This is the clinical picture. Proximal locking done by freehand technique. Post-operative follow-up steps. 80 plus minus 10 minutes. Range was 65 to 110 minutes. Average fluoroscopy during surgery was 38.5 plus minus 6.5 seconds. The range being 10 to 50 seconds. The average time of funial fracture was 8 weeks after surgery, with fracture healing time was 12 weeks. Average hospital stay was 10 to 12 days. All patients followed up after 2, 3, 6 and 2 or nail. No one complaint of knee pain. No reduction loss or significant displacement of fracture, lower third tibia, AP and lateral view, post-op X-ray of lower third tibia, AP and lateral view. Fractures, lower third tibia, again second case, AP and lateral view, post-op X-ray picture, AP and lateral view. Third case, pre-op X-ray, upper metaphyseal fracture of tibia, and this is the post-op X-ray of upper third fracture of metaphyseal tibia. This is fifth case, the lower third very low fracture of tibia, and this is the post-op AP and lateral view. This is the clinical picture 3 weeks after the surgery. Duration of this surgery, the number of patients included in this study was small. The study was not comparative with the standard technique. The status of cartilage over the patella and trochlea post-surgery has not been evaluated. Thus, furthermore study with larger population and long follow-up time is required to compare this innovative technique with a standard technique of suprapatellar nailing. In this technique, fluoroscopy time was slightly more than the standard technique because both distal and proximal locking were done by freehand technique. Finally, friends, smaller and medium class orthopedic hospital. If the only disadvantage of this technique is the slightly more radiation occurs because the locking, both proximal and distal, are done with freehand technique. But this can be lessened by gaining more and more experience in freehand technique for locking proximal and distal tibia. Thank you. The number one myth is interlocking nailing of humerus will severely impair the shoulder function due to rotator cuff damage. The reality is, with proper technique and entry point, the rotator cuff damage can be minimized and shoulder function can be preserved. So the myth number two is there is always chance of radial nerve injury as it is a complication for the interlocking nailing of humerus. And it is not a complication for the open reduction and internal fixation for plating. So it is, yes, it is, there is risk of radial nerve injury when the fracture is at the spiral root. There is chance of the radial nerve injury, but in the rest of the part, if the fracture is in the rest of the part of the humerus, there is minimum chance of the radial nerve injury when the instruments like the guide wire, remote, and the nail is introduced after proper reduction of the fracture in the distal fragment. Both AP and lateral view, the fracture is reduced properly. Only then these instruments are introduced inside the distal fragment. And don't allow your instrument to wander inside the soft tissue. So these are the two myths which is associated with interlocking nailing of humerus, and other two controversies whether which position of the patient should be used for the interlocking nailing of humerus. There are three positions. Number one, supine position. When it is used, it is comfortable for the anesthesia point of view as well as the surgeons. But the distal locking, which is done by freehand technique, is slightly difficult and tricky because the anterior surface of the distal part of the humerus is triangular. So finding the entry point for the distal locking is slightly difficult because slipping of the drill bit or TY. So it should be at angle, it should be introduced at angle, and then it should be kept in a straight line. So this is the disadvantage of supine position, and in lateral position as well as the prone position, the distal locking is done from the posterior surface, which is flat. So the entry fold, finding the entry point for the distal locking is easy because the surface is the flat, but it is uncomfortable position for anesthesia point of view, and the surgeons, it depends on the surgeon's choice. So I do use supine position for all my interlocking nailing. Number three controversy is because it is non-weight bearing bone. So one screw distal and one screw proximal is sufficient. But I use 2 screw distal and 2 screw proximal because the 2 is always better than 1, always stronger than 1. If it is just like the 2 kidney present in human body, if one fails, other start working. So, and 2 engines in the aeroplane, one engine fails, the other start working automatically. So, if one screw is not working, then the other screw will do its work. So, the fixation is better by 2 screw proximal and 2 screw distal. So friends, these are the advantages of interlocking nailing over the plating of the humerus, and these are the myths and these are the controversies whether 2 screws should be put proximal as well as the distal, what position should be used in this talk, and let us get tuned for the next video and subscribe my channel for more update on orthopedic surgery and insight.
Choose from thousands of realistic voices to use in your content. Change the way you record
ये है मिस्टर प्रशांत कुमार जो असम से आए हैं। उनके दाहिने कूल्हे का एक्सरे पिक्चर जैसा कि कूल्हे का हड्डी, कूल्हे का गोला, इसके कारण काफ़ी रेस्ट्रिक्शन मूवमेंट में उनको हो रहा था। वे ठीक से बैठ भी नहीं पाते थे कुर्सी पर। ये है एक्सरे पिक्चर, जिन्हें टोटल कूल्हा उनका बदल दिया गया है ऑर्थो सर्जिकल केयर सेंटर में, और 10 दिन के बाद वो वॉकर पे चल रहे हैं और फिर सीढ़ियों से उतर रहे हैं। इसमें ध्यान ये रखना पड़ता है कि उतरते समय पहले प्रेशर वाले पैर कूल्हा को बदला गया है, उसको पैर रखना, उस पैर को रखना है, उसके बाद अच्छे पैर को रखना है, और चढ़ते समय पहले अच्छे पैर को ऊपर रखना है, उसके बाद जिसमें कूल्हा को बदला गया है उसको रखना है। ये अब ऑपरेशन के बाद ये कुर्सी पर बैठ सकते हैं, इवन लो चेयर्स पे भी बैठ सकते हैं, और काफ़ी कंफर्टेबल और पेनलेस मूवमेंट ऑफ नी जॉइंट आप देख सकते हैं किस तरह से खुद खड़े हो जा रहे हैं और लो चेयर पर भी आराम से बैठ जा रहे हैं। ये बिना सहारा के 10वें दिन बिना दर्द के चल पा रहे हैं।
छपरा के डॉक्टर आरसी ठाकुर ने हड्डी फ्रैक्चर के इलाज में क्रांतिकारी तकनीक विकसित कर देश भर में पहचान। ऑर्थोपेडिक एसोसिएशन के राष्ट्रीय सम्मेलन में उन्हें इनोवेशन अवार्ड से सम्मानित किया गया। यह उपलब्धि छपरा, सारण और बिहार के लिए गर्व की बात है।
इनोवेशन अवार्ड इंडियन ऑर्थोपेडिक एसोसिएशन द्वारा शुरू किया गया है, जो कि गुवाहाटी IOACON 25 में दिया गया है, और यह अवार्ड पूरा भारतवर्ष में 3 ऑर्थोपेडिक सर्जन को मिला है, जिसमें बिहार से मेरा ही नाम है। अतः छपरा जिला में जिला का कोई ऑर्थोपेडिक सर्जन या बिहार का कोई ऑर्थोपेडिक सर्जन को पहले बार सौभाग्य प्राप्त हुआ है जिसमें मेरा नाम आया है। The supine position of the patient with a bump in the interscapular space, in which position I do interlocking nailing of humerus. With the traction only, with the assistant, both sides, the traction is given, and external rotation of the proximal fragment is done with the hand only. As you can see in this picture, evident in the fluoroscopic picture, you can see, and I am externally rotating the proximal fragment to see the lateral view of the fracture. So after reduction of the fracture in both AP and lateral view and confirmed on the fluoroscopy picture, we make we introduce a 2.5 millimeter or 3 millimeter TMI or steamer pin percutaneously at the selected entry point, both in AP and lateral. The entry point is usually in AP view, it is at the point at the junction of the articular and non-articular fracture. And lateral view, it is in the line with the intramedullary canal. So, if the fracture is in the upper part, upper fourth of the humerus, the entry point is in the AP view, it is in intra-articular surface of the humeral head, because it should be in center in both AP and lateral view. So I am introducing 2.5 millimeter steamer pin percutaneously at the selected entry point. You can see this is the AP view. I am selecting the entry point. It is intra-articular portion of the. You can see in this picture, because the fracture is the upper fourth of the humeral shaft, and this is the lateral view. I am seeing it in the lateral view. It is inside in the line of the intramedullary canal, and it is inside the intramedullary canal in both the AP and lateral view, confirmed in the fluoroscopy picture. I am exchanging this statement pin with a kind wire. A 2 millimeter kind wire is exchanged for this statement pin, 2.5 millimeter statement pin, and after making a stand hole, after making a small bend in the rotator cuff, and this is my right wire is inside the proximal fragment in the proper position inside the intramedullary canal in both the lateral view, and you can see the fracture is reduced. And since your time, while introducing the fracture side, while crossing the fracture side and introducing the right wire in the distal fragment, it should be reduced, the fracture should be reduced in both AP and lateral view. And now I am inside the distal fragment. Don't put the guide wire inside the soft tissue and don't do try. Then this is the reading of the intramedullary canal. Serial reading is done. First of all, with the 6 millimeter reamer, and it is being read, and then the 7 millimeter reamer is used up to the lower end of the humerus. It is about up to the 2 to 2.5 centimeter, proximal to the 8 millimeter is the reamer is being used in this picture, as you can see in AP view, and it is crossing the fracture site. You take the proper time, and the fracture should be reduced while doing reaming, and it should not be in varus and valgus position, and it is inside the distal fragment. As you can see in this picture, the 8 millimeter reamer is inside the distal fragment, is introduced. So after reaming, we introduce a 7 millimeter nail of appropriate size with hand movement only. Don't use electric reamer or hammer. Only the last few centimeters of the nail is introduced by hammering. So it is a well-placed nail up to about 2 to 2.5 centimeters above the alveolar fossa. And now I am deciding where I should put my incision for distal locking. And this is the KY position on the skin, put on the skin horizontally, another KY vertically overlapping the nail and crossing the hole. So where the both KY cross each other, the bisecting point in the middle of the proximal or dynamic hole will be my point of incision in the skin. So after putting about 1.5 centimeter length skin incision, we do dissection, soft tissue dissection with the fingers or the artificers, and then a 1.5 millimeter KY, short KY is used to make a hole. After making both holes circular, the lower hole circular and relaxing the upper hole, dynamic hole in the plate as much as possible. And this is the 1.5 millimeter KY is being put. You see, this is put in angle because the shape of the anterior surface of the distal humerus is triangular, so it should be put in angle. So introducing in near cortex, we do drilling of the distal cortex through this hole, and after drilling we have put both the screws. You can see in AP and lateral view where side the screw and where place the screw inside the hole in both AP and lateral view. So I am putting the proximal screw down. You can see that the nail has been buried inside the both hole. Where side the screw in AP. Back hammering of the nail is done when required to reduce the distraction at the fracture site, to eliminate the distraction at the fracture site, and the fracture is compressed. But in this case, there is no distraction at the fracture site, and nail has been buried inside the intermedullary distal screw. And this is the view, and you can see the final position where two skin, both the screw and well buried nail about 5 millimeter from the articular surface. This is the fracture. You can see there is a comminuted fracture, there is no distraction. Okay, thank you. आज मैं आपको इंट्रामेडुलरी नेलिंग of long bones of human body के इतिहास के बारे में बताऊंगा। सबसे पहले मैक्सिको में 16वीं शताब्दी में रेसिनस वुड यानी कि लकड़ी का उपयोग इंट्रामेडुलरी कैनाल में डालने के लिए होता था ताकि हड्डी का जुटान हो जाए, लेकिन उसे असफल होना ही था कीटाणु संक्रमण के कारण, वो असफल हो गया। उसके बाद आइवरी हाथी दांत का उपयोग होता था, क्योंकि उसका रंग उस आदमी के हड्डी से मिलता जुलता था। तो ऐसा विश्वास था लोगों का कि 18वीं शताब्दी में ऐसा विश्वास था कि बायो फ्रेंडली और बायो कंफर्टेबल होगा, तो हड्डी के आदमी के हड्डी के साथ घुल मिल जाएगा। 1940 में असली क्रांति इंट्रामेडुलरी नेलिंग के क्षेत्र में हुआ, जब उनसब ने जर्मनी का सर्जन था, उसने सबसे पहले उनसब नेल बनाया और इसे के नेल भी कहते हैं। ये के नेल है, देखिए ये निकालने के लिए ऊपर में एक छेद है और इसमें निकालने वाला औजार को फंसा करके निकालते हैं और डालने के लिए इसको अपर एंड ऑफ द फीमर से डालते हैं। 1939 to 40 में इस नेल का उपयोग सेकेंड वर्ल्ड वार में सैनिकों को ट्रांसपोर्ट करने के लिए जल्दी से जल्दी उपयोग किया जाता था, क्योंकि फर्स्ट वर्ल्ड वार में थॉमस नेल और प्लास्टर का उपयोग किया जाता था, जिससे बहुत दिन तक मरीज को, सैनिकों को बेड रिडन रहना पड़ता था और बेड सोर और निमोनिया, किडनी फेल्योर और पल्मोनरी मरीजों का चांस रहता था। और इस नेल के आने से सेकेंड वर्ल्ड वार में जो सैनिक विभिन्न देशों से जर्मनी गए थे सेकेंड वर्ल्ड वार में भाग लेने के लिए, वे अपने अपने देश लौटे तो उनके देश में देखा गया कि इस नेल का उपयोग उन सब ने किया था सेकेंड वर्ल्ड वार में, और जल्दी से जल्दी मरीज उसमें खड़ा हो जाता था और चलने फिरने लगता था और ट्रांसपोर्टेशन आसान हो जाता था और हड्डी भी जल्दी जुड़ती थी, लेकिन यह लॉ नहीं था। तो 1950 में ही उन सब ने ही ये आइडिया दिया था कि अगर ऊपर नीचे इसको लॉक कर दिया जाए तो रोटेशन नहीं होगा, ये रोटेशन हो रहा है, ये घूम रहा है अगल बगल और ऊपर नीचे भी नहीं जाएगा, तो ज्यादा रिजिड और स्टेबल फिक्सेशन होगा। तो 1950 में आइडिया क्रूसर ने ही दिया था और इस नेल को भी सेपरेट होता है और जो इंट्रामेडुलरी कैनाल का है और नेल से ज्यादा कांटेक्ट हो और मोटा नेल डाला जा सके ताकि ज्यादा रिजिड और स्टेबल फिक्सेशन हो सके और जल्दी से जल्दी मरीज को हम लोग चला सके। तो ये कॉन्सेप्ट था 1950 में और 1970 में ग्रॉस एंड केम्प ग्रॉस एंड केम्प ने सॉलिड नेल को इंटरलॉकिंग नेल का इंट्रापेटलर रूप से करने का कॉन्सेप्ट दिया, जिसे ऊपर और नीचे दोनों तरफ लॉक कर दिया जाता है। और हालांकि ये कॉन्सेप्ट 1950 में उनसर नहीं किया था, जिसे डिटेंशन बोर्ड टूल ने कहा, और बाद में 1970 में ग्रॉस एंड केम्प ने इसको स्पेशल जिग बनाया, जिसके थ्रू अपर फ्रैगमेंट और लोअर फ्रैगमेंट में दो बोल्ट स्टैटिक और लॉकिंग, स्टैटिक और डायनेमिक लॉकिंग का को डाला जाता था टिबिया फ्रैक्चर में। तो उसके बाद फीमर फ्रैक्चर में भी इसको डाला जाता था। ये फीमर नेल है और डिजिटल लॉकिंग किया जाता है। तो ये फीमर नेल है और ये टिबिया नेल है, जो आजकल इंट्रापेटलर रूट से यूज किया जाता है। इसे सुप्रापेटलर रूट में भी यूज कर सकते हैं। तो upper fourth of the tibia fracture में in pull of the patella, तो इसको न्यूट्रलाइज करने के लिए, पुल ऑफ पैटला को न्यूट्रलाइज करने के लिए सुप्रापेटलर नेलिंग का कॉन्सेप्ट आया, जिससे 1996 में टोर्नेटा एंड कोलिंस ने ये कॉन्सेप्ट या सेमी एक्सटेंडेड पोजीशन, ये जो डिस्प्लेसमेंट हो रहा है 90 डिग्री फ्लेक्शन करने के कारण इंट्रापेटलर रूट के द्वारा नेलिंग करने में उसे रोका जा सकता है, क्योंकि वो पैटलर 2012 में एओ ग्रुप ने जॉनसन एंड जॉनसन के साथ मिल करके सुप्रापेटलर नेलिंग का चेक करता है और उसी के थ्रू रिमिंग, गाइड वायर और नेल को डाला जाता है ताकि इंटरआर्टिकुलर, और 35 से 40 लाख का इंस्ट्रूमेंट सेट आता था और 35 से 40 हजार का इम्प्लांट का खर्च पड़ता था। तो गरीब मरीजों के लिए छोटे छोटे नर्सिंग होम में इसे यूज नहीं किया जा सकता था, क्योंकि उसका कॉस्ट वहन नहीं कर सकती है, उतना महंगा इंस्ट्रूमेंट। उसके बाद डॉक्टर RC ठाकुर ने, डॉक्टर ठाकुर इनोवेटिव टेक्निक को इनोवेट किया, जिसमें फ्री हैंड टेक्निक से अपर एंड लोअर लॉकिंग किया जाता है और जिग का उपयोग नहीं किया जाता है। और PFN A2 सेट से ड्रॉपर एंड प्रोटेक्टिव स्लिप को यूज किया जाता था, क्योंकि स्पेशल इंस्ट्रूमेंट सेट का लंबाई चौड़ाई जो ड्रॉपर एंड प्रोटेक्टिव स्लिप यूज किया जाता है, तो उसका लंबाई चौड़ाई और उसका डायमीटर जो होल होता है उसको डालने के लिए, रिंग करने के लिए तो सेम ही था। तो उसको PFN A2 सेट का ड्रॉपर एंड प्रोटेक्टिव स्लिप यूज किया और एक कॉलर कोडेड टिबियल नेल एक्सट्रैक्टर, टिबियल है, टिबियल इंट्रापेटलर रूट का टिबियल नेल, मोहन, सोहन, राम, श्याम कुछ भी लिख सकते हैं। या इसमें हमने एक रेडियल सरफेस ऑफ द नेल से, तो थ्रू आउट द नेलिंग प्रोसेस एक, तो इस तरह से ये रिलेशन बना रहता है। तो जो इंस्ट्रूमेंट सेट का कॉस्ट 0 हो जाता है और नेल वही रहता है जो उनका पेटलर रूप से डाला जाता है। कुछ परेशानी आया नेल को डालने के प्रॉपर पोजीशन में, तो RCT ने प्रोड्यूसर कंपोजिशनर को बनाया गया, जिसमें नेल को डायरेक्ट कस किया जाता है और इसमें लॉक हो जाता है और लॉक करने के अपर लेवल ऑफ द कॉलर कोडिंग किया जाता है और इसमें एक बीच में इंस्ट्रूमेंट के बीच में RCT ने प्रोड्यूसर कंपोजिशनर में सेंटर में एक होल होता है, जिसमें टॉमी बार लगा करके नेल को पोजीशन में रखते हैं। जब हम हैमर करते हैं तो धीरे धीरे नेल रोटेट करता है, आइदर एंटी क्लॉकवाइज या क्लॉकवाइज। तो इसको रोटेट करके प्रॉपर पोजीशन में रखते हैं और उसके बाद नेल को अंदर डाल देते हैं till last तक। So thank you very much for patient hearing of history, बहुत ही रोचक हिस्ट्री